Hello and welcome to Living the Dream for General Practitioners, the podcast for doctors and clinic leaders who want to learn about pathways, strategies and opportunities for living and working in Australia. Join me, Gemma Gough, and my expert guests as we share stories, unlock the secrets to recruitment success, share tips for moving across the world, navigating new cultures and so much more. This show is brought to you by Recruitment Australia. Now sit back, relax and enjoy this episode. Hello everyone and welcome to another episode in our Living the Australia Dream podcast series. My name is Gemma Gough. Thanks for joining me today. So today I wanted to talk to you about income for GPs. It's a question we are often asked. How do I get paid? How does Medicare pay me? How does a clinic pay me? How does the income stream work? So I thought I'd spend a bit of time today going through that with you. So many overseas GPs are salaried, so you are paid an hourly rate to see a certain number of patients and generally have little or no control over your schedule. Well, in Australia, that's quite different. So GPs are generally independent practitioners, which means that you're self-employed, you're responsible for your own income, and so if you're not seeing patients, you're not earning money. GPs, as part of being an independent practitioner, pay a service fee. So we'll talk about that a little bit later on, but essentially a percentage of what you earn is paid to the clinic for your room hire, your medical consumables, IT support, the clinical and non-clinical support that is provided in the clinic, and then you get to keep the rest of the income. So when you start at a practice, you generally have conversations with a practice manager or general manager about what you'd like your clinical sessions to look like. So how many patients an hour you would like to see, and the start and finish times of your consults. And once you've discussed that, you would also want to discuss things like working evenings and weekends. Many clinics are very keen for you to do that. There is a big demand in the community for those out-of-hours consults. Well, there's certainly some financial incentive to doing that. Medicare does provide a higher rebate, and generally most clinics provide or charge a higher gap, the co-payment, which again we'll talk about in a moment, for those out-of-hours consults. So it's certainly worth a consideration if you're looking to reduce your hours but wanting to keep the same level of income that you've become accustomed to. So once you've agreed on your sessions, you'll talk about the types of patients that you want to see. Now, generally, when you start in a clinic, you do tend to see the medical certificates, prescriptions, those sort of in and out type consults. As you begin to build your patient relationships, then you will start to see more regular patients and be eligible to charge Medicare for consults that are part of the chronic disease management plans, which again we'll talk about in a moment. So, you might have special interests, skin, pediatric medicine, whatever it might be, and share that with the practice manager when you start so that they can promote that as an interest for you, which allows you then to be working, in an area of your special interests. So to give you an idea of how the income works, we'll talk about patient Mrs. Smith. So Mrs. Smith attends a clinic. You open her file in the electronic patient records, and generally a timer within the notes starts ticking. And you have your consultation, you finish writing your notes, and you end the consultation with Mrs. Smith, and you can finalise the visit in their medical records. When you do that, a box appears which allows you to select an item number from the Medicare benefits schedule, which you then send off to Medicare for payment. So there are generally 4 main numbers that are used for standard consults, and item number 3, which is a consult of less than 6 minutes. A 23, which is pretty common, is a consult between 6 minutes and 20 minutes. Item number 36 for a consult over 20 minutes, and then 44 item number for a consult over 40 minutes. So each item number on the medical records there on the fee schedule will have a brief description of which you must be compliant with to be eligible to bill Medicare for that item number. You need to ensure that you're compliant at all times to avoid any repercussions, any audits or paying monies back to Medicare. You can Google the Medicare benefits schedule and do some training before you arrive and start to get your knowledge, to grow your knowledge in that area would be certainly of value. GP practices in Australia are run independently to hospitals. So the billing structure is slightly different. Now, anyone in Australia who is an Australian citizen, a permanent resident, or has a reciprocal health agreement is generally entitled to free Medicare. It's essentially paid for by the taxpayer, but free treatments in the public hospitals. So, but in general practice, practices are privately owned. So they can make arrangements to charge an out-of-pocket expense to patients, and that can vary state to state, clinic to clinic, which can be based on demographic or all sorts of things. Some clinics do bulk bill, meaning they do charge just Medicare for a consult, and so there's no out-of-pocket costs for patients. Those clinics are few and far between now. It's just not really financially viable for a clinic to work like that. So more a transitioning to what we call mixed billing, which means some patients are bulk billed and some are charged a co-payment. There are some fully private clinics, not so many. Mixed billing is generally what is common. So in regards to sort of those out-of-pocket costs, once you've processed your item number within the patient records, it raises an invoice. So Mrs. Smith then goes back to the reception desk where the receptionist will take payment from Mrs. Smith. So if you decide that you want to charge Mrs. Smith for an item number 23, a standard consult, and you want to charge a gap or a co-payment for the consult as well, then that's entirely up to you. You may have a practice policy around this. Again, that's something you would need to discuss with the practice manager when you start. So let's say, for example, the practice that you work at is $20. So Mrs. Smith has her consult with you. She goes back to reception. You would raise an invoice for the standard consult with an item number 23, and you make a note on there that you would also like to charge a gap. So Mrs. Smith pays for the item number 23, which at the moment equates to $41.40, and the $20 gap. So she pays upfront $61.40, which goes directly into your bank account. Majority of patients pay by card, so she taps her card on the payment machine and pays that money to you. She then taps the card again, and that's at the point Medicare gives her back $41.50, which means that she's only out of pocket $20. So this is where Medicare is paying the patient back, not the practice or you. So the patient has to pay up front for all of the funds and then is reimbursed by Medicare. Hopefully that makes sense. It is worth noting that there has been a Medicare freeze for quite some time. So there's been little increase to the rebates from Medicare for quite a few years. There's been slight adjustments, but nothing big, which does mean that general practices generally review their co-payment, those out-of-pocket costs, on a sort of an annual basis and generally increase those in line with CPI or other operational costs that they need to cover. For bulk billing clinics, there's no out-of-pocket costs. So the patient essentially comes straight back to reception and they give permission for you to be able to bill Medicare directly for their consult. Of course, they're going to agree to that. They press a button on a machine which gives that authority, and the money is then put into your bank account directly from Medicare. There is an opportunity to bill Medicare for item numbers with a higher rebate. Now, this generally doesn't happen for the first few weeks of you being in the practice because, as I mentioned before, you do tend to see the prescriptions and medical certificate type consults initially. And there is a bit of an eligibility criteria for you to be able to bill those higher rebate items, you being the patient's regular doctor being one of them. So, for example, if Mrs. Smith becomes a regular patient of yours and she has a chronic disease and she needs a GP management plan, you'd be able to bill item numbers such as a 721, which can be charged directly to Medicare with no out-of-pocket costs. And at the moment is about $158.80 for that consult. So again, Mrs. Smith will go back to reception. She presses a button to authorize Medicare to pay you directly for that consult. Now, to get this, there are certain criteria to be met, and there is the simplest thing to do is to put it into Google to learn how to bill those item numbers. You really do. I can't stress enough how important it is to be compliant. There are certain things you have to do in that consult, certain things you shouldn't do in the consult to be eligible to bill those item numbers. It starts to get a little bit tricky when you want to work out what item numbers you can bill with others. Some are time-based, some are not. Some item numbers you can't bill with others. It can be a bit of a minefield, but any good practice that you join will make this part of their orientation for you, so that you can learn all about Medicare. You can sit in with other consults. Some clinics arrange for Medicare educators to come on site and provide education around smart billing, so that you're not having to work really long hours to have a good income. You just bill smarter. So, there are ways to improve your education in regards to Medicare compliance and billing. If you are non-compliant, Medicare can and will audit. So this usually means reviewing your clinical notes, looking at item numbers. If you're billing lots of high rebate items, it's just a red flag for Medicare to do an audit. If you are found to be non-compliant, you will be expected to pay back the money for the consults that patients weren't eligible for you to be billing. And it is likely that that sort of behaviour will also trigger an audit for your colleagues at the practice as well, which I'm sure would not be welcome. So, please be really careful and do your research and due diligence in that regard. As you can imagine, if you're seeing around 30 patients a day and you've got money flowing in from the accounts, it can be quite overwhelming for your accountant to reconcile those, particularly when it comes to sort of end of financial year tax return time. So we would recommend you open yourselves a business transaction account. That means that monies flow into that separate account. So this is completely different to your everyday spending account. You have all your patient monies deposited into your business transaction account. Then generally your service fee invoice is raised, say, fortnightly, and it might be 30% of your income. So that will be paid out of your business transaction account directly to the clinic for those service fees, your room hire, your IT support, etc. And then whatever monies is left, you can then transfer to your everyday account. So, and then starting the whole cycle again, and your accountant will love you for being that organised. So I would strongly recommend you look at doing that. Once the service fee has been paid, as I say, you can move that to one side and you start the whole process again. If you find that at the end of the sort of fortnightly period or whatever your service period is, that the funds don't quite tally up to your reports, which you can find in your medical software, I would suggest speaking to your accountant, but generally there's a bit of a lag between Medicare processing the payments and the money's being received into your account. But again, good practices will explain all of that to you when you start. As I say, each practice is slightly different in terms of how service fees are paid. But in regards to how you bill Medicare and the patients, what I've shared is generally how it works. All good practices, as I say, will provide you with education around MBS and the PBS as well. So your prescriptions, how you can prescribe, what you can prescribe, which are covered by Medicare or subsidized by Medicare, and which prescriptions are privately billed. So and there's lots for you to learn, but there's also lots of resources to help you as well. So, do your research before you arrive in Australia so that you're well prepared when you get here. There are some courses that you can attend as well in regards to that smarter billing. You might spend a few $1,000s attending a course, but you certainly make that back pretty quickly once you get your head around the new billings, what item numbers you can bill with others, and little things like dipstick urine testings that you can charge an item number for, things like that are often forgotten. So they're good courses to invest in when you first arrive in Australia as well. Well, I hope all of that made sense. I appreciate that's a lot of your information, but thanks for joining me today, and I hope to see you all again soon. Bye for now. Thank you for listening to Living the Dream for General Practitioners. Don't forget to subscribe on your favourite podcast player so you don't miss an episode. At Health Recruitment Australia, we want to see more happy GPs, thriving medical practices and healthy communities. If you'd like to join us on our mission, visit healthrecruitmentaustralia.com.au to explore opportunities and get in touch. Thanks for listening.